Yeah, that's probably probably why I have the wee sweaty emoji this morning. But no, that's hopefully this morning. It's just to give you a bit of a opportunity as well. I've got a few slides that I will share in a moment, just to sort of talk through the assessment more broadly in terms of the actual service improvement plan, and then we can kind of go through some of the detail of your assessment. But obviously you do have the assessment guidance, and I'll say that a few times, that is available on the Coventry platform, and I would always suggest that you look at that and relook at that and relook at that if needed, because there are some obviously specific submission instructions that you do need to follow. But more broadly, in terms of the fact that you have to present a service improvement plan, I'm going to take us through that a wee bit today, just to give you some thoughts around what that might look like. And then obviously we can have that chat about the actual practicalities as needed. So if I can just share my slides. I'll do that now. I just share the application, I think, is it application? I think it always goes to the wrong way first, so you can maybe check, Chris, just...
Yeah, we had a little bit of a nightmare with it yesterday. Zoom seemed to be very, very slow, and I was struggling. Even when I was pressing the buttons, it didn't come up. Right.
Okay,
we've got your screen, but not in slideshow at the moment.
So that's interesting, because I've got it on slideshow, resume slideshow. Of course, I work with two screens, so on one screen it seems to be in slideshow, and one slide screen it doesn't like stop sharing. I'm going to do it a different way. Sorry about this.
Crystal's on hand.
I'm going to just do screen, I think. So what can you see just now?
Right. Yeah, we've got.
And it's got
on your wrong screen. You need to switch.
Yeah, that's fine. It says no notes in the thing. Is that it now coming?
Brilliant. Perfect.
Yeah, fine. Sorry about that. This is the advantage, although it's being recorded, we can edit those little bits out. so that anyone that's watching it later doesn't see me needing to worry about the screen. So yeah, as I say, this is just a bit of an overview this morning about the service improvement plan as a whole, thinking about that obviously, because that is ultimately what you are producing, and your assessment is the presentation of that, of your service improvement plan. So we will just go through that just now. So just to highlight, obviously you know already, because you've already submitted a formative assessment, that this programme has 2 assessment points, which obviously one of which for the accredited pathway you have that formative opportunity for your formative assessment, and you should hopefully have already had the feedback. I believe that is already available on Aula. So if you've not already accessed that, I would encourage you to go into your Aula platform and access that and have a look at that feedback.
Caroline, can I just jump in a minute?
Yes.
I don't know if this slide's supposed to have anything on it, but
not yet.
That's all right then.
That's okay. That's not yet. That's okay. Thank you, Chris. So yes, you'll hopefully already have that feedback in Aula, so make sure that you have accessed that, and obviously you're going to use that feedback, or the idea is that you use that feedback that you've received to help you in the development of your summative assessment as well. The summative assessment is ultimately there to evaluate your learning at the end of the programme by comparing it to against the assessment brief and the related university academic standards for whatever level of study it is that you have selected to follow. So whether that be level 6 or level 7, that will obviously be assessed appropriately at the end of once you've submitted it. And the summative assessment is worth 100% of the marks. So although you've obviously have submitted that formative assessment, that is literally what it is. It's a forming, it's an information, it's an opportunity. Effectively, it's an opportunity, yes, to get feedback that will hopefully support you in the summative assessment, but also allowed you to have a bit of practice, dare I say, in that sort of creating that narrated PowerPoint, uploading it, submitting it. So whilst that might have felt a bit sort of stressful and hopefully not too stressful, but I appreciate probably it possibly did, it's given you that opportunity to know where to go on the platform, have that opportunity to upload it. Any issues, hopefully, that you had at that point, you will now have a better idea of what to do when it comes to the summative assessment, which, as I say, is worth the 100% of the marks. And then to pass the assessment, you need to achieve a grade of 40% or above. So if you obviously achieve 40%, or above, you will be awarded your 20 academic credits at whatever level, level 6 or level 7, dependent on what you have selected and being expected to submit. And that's where obviously the learning outcomes for whatever level it is that you are studying are really important. That again, that you revisit, you look at those learning outcomes so that you are familiar with what is expected of you at that level of study. And then obviously when it comes to your presentation, that is what they will be looking at, that you will have met those learning outcomes as part of your service improvement plan, that you're evaluating, you're critiquing, you're analysing. And again, it depends on your learning outcomes in that. So let's move on. So what is a service improvement plan? You, as I say, you'll hopefully have already started thinking about it, and you'll already have started to get some ideas together, and you'll be working on it. But ultimately, it is that formal plan that's used to introduce the steps that should be taken to identify, assess, implement, and evaluate a service. The purpose of the service improvement plan is to give you that opportunity to plan and evaluate one area of practice that will improve the service for the people that use the service, or indeed the people that work within the service. You might have selected a sort of patient or a service user area to improve, or you might have selected something that actually affects the staff, and that's okay. Either or is fine. And it could be developed to obviously consider areas of improvement identified by service user feedback. It might have come from quality indicators or governance reports that have shown that improvement is needed. It might have come from topics within the programme that you feel could be expanded upon within your area of work. It could be that there's national or regional or local areas of practice that you're aware of that you know that you need to improve within your service. Or it could be that there's been the introduction of guidelines, protocols, or standards in practice that you need to take forward. And that is the area in which you look to do your service improvement plan. So when it comes to constructing your service improvement plan, obviously we're all individual, but it is good to have a solid structure to it. So whilst we do all have our own ideas, and it will be very personal to you because it will be pertinent to your area of practice, which is very different to potentially someone else on the call, the actual overarching sort of structure within that could be and should be, quite linear in that sense, because obviously you want to get the messages across so that anyone watching the narrated PowerPoint, because whilst you're using it for your assessment, or you will be using it for your assessment, you actually might find it's a useful tool to share with colleagues or management within your clinical area, that you can show them what you've produced as part of this program, but also as potentially as a mechanism for supporting you to take forward the actual service improvement within your area. So the method of assessment for this program, as we've mentioned before, and you should know because you'll have hopefully looked at your summative assessment guidelines by now, is a 20-minute recorded narrated PowerPoint presentation. So in effect, you'll be using that method to present your service improvement plan. The narrated PowerPoint presentation gives that kind of dynamic way, or an approach that combines the kind of visual elements of, text, data, images, graphs, and or videos maybe, with that kind of audio narration that you will be providing to enhance the clarity and the impact of the information delivered. And you need to integrate that critical analysis with the multimedia strengths of PowerPoint to create that engaging platform to communicate your insights effectively. And the objective is to demonstrate your understanding of service improvement concepts, methodologies, and that kind of practical applications to the identified area of practice. It's also there to help develop your kind of leadership skills to advocate for and implement infection prevention and control protocols and policies. And it also enables you to prepare for the challenges that directly impact IPC practices, and enable you to kind of take forward and lead and manage those IPC initiatives as well. And obviously to ensure that you're maintaining those high standards of infection control and promoting that safe healthcare environment. So the narrated PowerPoint must be a maximum of 20 minutes. And there is a penalty of 10% of the overall marks if you exceed that 20 minutes. In fact, it's not just if you exceed it, it's 10% either side, as it would be if you had an essay to submit. You always are allowed a sort of 10% either side. So effectively, you'll be given grace if your presentation is anywhere between 18 minutes and 22 minutes. That would be considered okay, and you will not sacrifice any marks if you're within that range. If you fall out of that on either side, so perhaps your presentation is too short, or perhaps you've been over keen and you're wanting to share so much that your presentation is over that, you will be penalized. So I guess that's one area that I'm always a bit of a real stickler about, whether it's a narrated PowerPoint, which is what you're doing, or whether it was an essay, or whatever the medium is that is being selected for the assessment, is about really trying to stick within that allowance. There's no point giving away marks that you don't need to give away if possible, because obviously you just don't know where other things might be picked up on. So again, really important to take a note of the time limit, practice, really aim to get into that in that range between 18 minutes and 22. Obviously 20, very hard to, especially when you're narrating something, it's very hard to sort of hit things on it exactly, as it is very hard to hit anything if you're writing something. So just that wee bit of allowance allows you to go up and down, but just to keep that in mind. So when you think about constructing the service improvement plan, now I was maybe a wee bit hungry when I wrote this. I've decided to look at it. I got this actually idea. I'm not gonna lie. Chat GPT helped me to come up with a bit of a concept of how could we structure this service improvement plan, and I really like the idea of the perfect presentation burger. And as I say, I was actually kind of hungry at the time, so it really helped me. So yeah, creating that presentation is pretty much like this nice juicy burger. Now, I get that not all of you might want the same fillings, and that's fine, but the concept is there. So you need all of the layers to make it really satisfying. So the top bun is that introduction. That is the sort of setting the stage and giving that context, and it makes that audience that you're preparing for hungry for more. You know, just you're starting to really entice them, thinking, God, yeah, I'm ready for what's to come. Then you have the juicy filling, that kind of the main body of your service improvement plan, and that's the meat in the middle, or obviously if you don't eat meat, the plant-based whatever, is, and then that's where all the flavors come in. And you have that core content. That's where your evidence, obviously, you want to really use your evidence and your analysis. All is all jam packed into the middle of that kind of really juicy bit in the middle, and ultimately that's what the people come for. They want the bit in the middle. Most people don't want, well, they might quite happily have the bun, but they really want the meat in the middle, or whatever is your selected option for the middle. And I guess that is actually, again, quite a good reference for the fact that whatever sits in the middle of that bun is, like I said at the beginning, that will be very different for each of you. You know, you will have your own preferences, you'll have your own areas of work, and you will have to, you know, your own challenges, or and you'll have your own different sort of stakeholders that you need to think about and consider when you're constructing this service improvement plan. But ultimately, the actual concept of it all being put together is important. And then you have the bottom bun, which is the conclusion, which is then everything that kind of just holds it all together. And that's you kind of reinforcing the key takeaways, and that kind of leaves the lasting element of the burger. And just to keep in mind that obviously if there was no bun here, that equals a messy bun, a messy disaster ultimately, because you don't want to serve your audience just the bit in the middle, because then they'll be kind of left confused and they'll be kind of a bit unsatisfied with what actually the messages are. So I hope you can get my idea. I quite like the idea myself, and I thought, you know, that makes sense to me. And as I say, I was peckish when I was creating it. So I thought, I get that. That's fine. So if you start to breaking it out down and you're building it up and you're thinking about the top bun, that introduction, you want to begin with an introduction that really outlines what your presentation will cover. And then you want to introduce your service improvement plan as well. Why are you planning to, you know, why are you doing what you're doing? Why are you undertaking this service improvement? And what is your interest in this area as well? You want to take the opportunity in the introduction to clearly outline the aim of your service improvement, and your project aims obviously should be, and outcomes need to be clear and smart, which I'm sure you'll be aware of. And they also should be ultimately kind of aspirational, measurable, really important, and then consistent as well with local and national priorities and plans. And you would want to be able to evidence that in your introduction and make any necessary references that you need to highlight how that is consistent with local and national priorities, or how that fits or doesn't fit with the evidence, or why, that basically gives you that evidence of why you are doing what you're doing, what has driven you to select this area, and the real why. Then we'll go into, you would want to go into the middle. Obviously, that's, as I've said, you'll be starting to think about the main body of your service improvement plan. And that's really, as I've said already, where you make it your own and then really relevant to your own area of practice. And obviously bringing in the learning from the program and how the learning of the program fits together or has shaped your own individual service improvement plans, and obviously within your clinical area. So you're not just using this service improvement plan, or certainly not using this the presentation just to show everything that you've learned about infection prevention and control. It's really that coming together of how the learning is supporting and shaping and directing your service improvement plan, rather than just, here's everything I know about IPC, when actually it's, well, here's what I know about IPC, and this is why it's important. This is why this learning has helped me to develop this idea. This is how, the data within my clinical area has also shown me that there is an issue, and actually when I've read the evidence and the guidance, this is why we're doing what we're doing. So you'd want to, the key areas that you'd want to consider in the main body would be around that kind of background, giving a background, defining the problem, using that supportive data and evidence and the literature as well to support and emphasize the significance and the value of your plan. You would want to provide an overview of its the context, obviously, the relevance, and the potential impact on outcomes. You want to be thinking about and certainly introducing the strategic drivers for your improvement and how they address a key issue, the key issue that you're wanting to focus on within your chosen area of infection control, and how does that align to your organizational goals as well. And also taking this opportunity in the background to demonstrate how you've utilised project management tools or methods to help you identify the problem and to evaluate and analyse the key factors as well. You also want to, in the main body, you might, areas that you want to consider is around your existing service delivery and training needs. So you would want to maybe put a bit of appraisal of your existing service delivery, reflect on any learning gaps and the needs within the context of your service improvement requirements. You would want to also think about discussing, or not think about, you would want to discuss how these learning gaps and needs affect current practice and outline where that improvement is needed. And then also obviously ensuring that you're analysing rather than just describing. So focus on how addressing the gaps can enhance service delivery as well. Then you would want to move on to the sort of purpose of the service improvement plan. That's really starting to expand on what are the goals that you're setting out to achieve, clearly stating them, obviously as SMART objectives would be ideal, and the planned outcomes for the project as well. What are the benefits? What are the local, regional, national, perhaps even the international agenda that does this support? And what are the key milestones to be achieved, and in what timescale as well? And what are the key constraints or barriers to overcome? And then also, what evidence-based change frameworks and strategies will guide your improvement? And also starting to think about and obviously highlighting around giving consideration to the potential challenges of that as well. Other areas to consider within this sort of real main body and within this sort of real nice bit in the middle is around the leadership, the stakeholder analysis, and the resources as well. So what leadership strategies will you use, and how will you engage with stakeholders? What role, influence, and importance do these stakeholders have? How will they help shape your plan and its outcomes? And also, I would certainly be considering including a stakeholder analysis. So you might be referring to that stakeholder analysis in your presentation. And if you have completed a stakeholder analysis, an actual template as an example, then you can include that as an appendix. And throughout your presentation, you would have obviously referred to that in this reference to stakeholders. And then that could be added as an appendix as well. So you want to consider and discuss the actual leadership values, the skills, and the behaviours perhaps required during that implementation of change in practice, and ultimately, how will this encourage that collaboration, the engagement, and the successful implementation in relation to your plan? And then also, what resources do you need to complete your project, including that time scale and costings as well? And finally, but no less important, is around evaluation. So again, in that main body, you would be wanting to think about what is the projected outcome of the plan, and how will you plan, or how are you planning to measure impact? What evidence-based methods will you use? And the evaluation methods that you use should ultimately align to the objectives outlined in your proposed plan. So if you have clearly stipulated your aims within that plan, then you would obviously want to be evaluating how are you going to evaluate and measure the impact of those aims, and also giving consideration to demonstrating the sustainability of your project and the improvement going forward, and consider it if there are any kind of risks to that improvement that may be lost over time as well. So start to really think about the potential challenges and how this might move forward, not just I've created this plan for this program and my plan is great, but actually how are you really going to take that forward in practice? Or what might you come up against in practice to put that into reality? And then we have the bottom bum, the conclusion. So finally, it needs to rest on everything needs to rest on that bottom bun, and that's where you're pulling together all of the key points that you've made. You're briefly summarizing your key arguments and key findings. And I guess the important element here in the conclusion, in that bottom layer, is that you really avoid introducing any new material. So if there's something that you feel like you want to say in the conclusion that you haven't already said, then it should be in your main body, or you don't include it, because the conclusion is not where you start introducing any new ideas. It is really just that coming together. So having worked through all of those areas, what have you come to? What is the conclusion that you've come to at the end? And I guess just thinking about, as I've said already, and I said I would come back to it, very important is to read the assessment guidance that you have, that's available on the Coventry platform. Really familiarize yourself with the learning outcomes for the level in which you have signed up to study, because they are slightly different. Obviously they should be different because they're different level of academic requirements. So familiarize yourself with that, because that is what you need to evidence, that you're learning, your service improvement plan needs to show that you have met those learning outcomes. And obviously, really importantly, reach out if you need support. Now, obviously, if it's specifically about the assessment, it's probably better to go directly to Coventry. But obviously, if you're having challenges there, then coming to us, and we can obviously try and support where we can, and or try and get that into to Coventry if there is any issues specifically around that. As I said, I haven't put them on a slide because they're obviously part of the Coventry assessment guidance, but there are some specific submission instructions that you do need to be aware of. So I've got a sheet here that I've taken from their guidance, but I haven't put it on the slides because you do have it in your guidance anyway. But just to go over some of those so that you have that. As I say, your 20-minute narrated PowerPoint presentation needs to be submitted for you to obviously, hopefully, achieve your academic credits. It must be uploaded to Handin by 6 o'clock on the day of submission, 6 p.m, so 1800 hours on the day of submission. The final submission link will be opened 2 weeks before the submission day. So those of you who are super keen or super organized can submit anytime between that 2 weeks up to the submission date. But once it's submitted, it's submitted. So obviously keep that in mind. Submissions are made on the Aula site, and you should be submitting as a narrated PowerPoint only, although I do think that also includes like an MP4. I think Crystal can correct me if I'm wrong, but I'm sure that was accepted as your formative. So actually, as the narrated PowerPoint or the sort of MP4 video of the PowerPoint, because you have to be able to hear the narration. So you cannot submit it in any other format, such as PDF or anything, because then the narration can't be heard. So you do need to submit it in such a way that the narration, you speaking, can be heard as well. The cover slide of your presentation, you should include a cover slide, and that should identify obviously the program that you're the module title that you're studying, and the code, which again is available on the actual guidance. So you can just copy it from there. You should have your student number, which again is your Coventry student number, and the length of the presentation in minutes and seconds. So again, you're just highlighting on the cover slide that this presentation is 20 minutes and 2 seconds long, whatever, but somewhere between that 18 minutes and 22 minutes, you will not lose marks. Anything below or above that, you will lose marks for being out with the time limit. And obviously the slide should have the key points that you want to discuss and develop, and then you're developing those points in your narration. So you're not trying to get everything and all your service improvement plan information on the slides. The slides are just there as the prompt. What gives them that meat, what gives them that real juicy information, the bit that's really important is your narration. You're adding to what's on the slides, obviously. And again, I would really encourage you to try and avoid busy or confusing slides, and that can be challenging sometimes, but really, really try and work on keeping the content minimal on the slides, and then really developing your ideas and your thoughts, and your providing the relevant references. So if you are referencing something, you should be saying that, according to whoever, the year, you should be stating your references throughout, any evidence, any examples. And obviously if you're, quotations, you would want to have that in the quotation marks, maybe on the slide. It does suggest in the guidance that aiming for 1 slide per minute of speaking time. But again, really practicing to ensure that you stay within the time allotted is important. Templates, again, it'll be up to you how you want to. I mean, some of you will be really, really creative and come up with some really good ideas and concepts to get over your message. Some of you might be less so. You might get those ideas elsewhere, but then you're building on it ultimately. So although you might get those ideas from elsewhere, you have to build the information around about it. But you would want to ensure that you have a consistent theme throughout. So that consistency of font style and colors and kind of layout across your slides would be important. You wouldn't want to have completely different things on all the different slides, or that becomes quite a jarring thing to watch and listen to. Your camera should be on. In fact, it has to be on. You must have a camera on when you record your presentation, so that when the presentation is played back, the marker obviously can not only hear you, they can see that it's you presenting that presentation, and they, to be able to speak and hear you clearly. And then finally, on your final slide, that would be where you would include your reference list. So as it would be if you'd written and submitting a written example of your plan, you would have a reference list of all the references and the evidence that you've referred to within that presentation. And that is for information only. So that does not need to be read out. Your reference list does not need read out, and it's not included in the time allocation. So when you deliver your presentation, make sure your reference list is there, but you don't need to obviously go through it or anything when you're delivering your narration. It does need to be in the APA format, which again, Coventry has access and guidance to support APA, so that you know what that should and could look like. And just check that you include all the slides in the correct order in the final version before submission as well. And I suppose just to finish that sort of summary around this, when you're thinking about your next steps and you're thinking about the submission instructions, it is a professional and an academic assessment. So please obviously consider that and present yourself when you're in an environment that would reflect that. So you would want to be in a quiet space, with no one else in the immediate area while you're recording that narrated PowerPoint. You want to maybe give some thought to the background. I know that can be sometimes a bit challenging. I think I've got a bit of a blur on just now. That's fine. Again, you would be wanting to think there's nothing in the background that individuals shouldn't be viewing or seeing. And again, just a point of note, because it is a professional and academic assessment, confidentiality is vital. So if you're referring to your clinical area, you want to talk about it, you want to talk about it in the generic terms. Don't give the actual detail of where that is, and certainly don't be including any individual names or places in that sense. So if you worked in an acute ward, perhaps that's fine. You may be a renal unit. You wouldn't be wanting to refer to exactly where that is, and you certainly wouldn't divulge any personal information about individuals, patients, or staff, either way. And I'm assuming, because most of you if not all of you, will have submitted your formative assessment. You will have had access to the PowerPoint, because I know that Coventry does provide all students that free copy of Microsoft Office 365, which has record voice narration to PowerPoint for PC or Mac. So if you have had any issues and you're still having issues with that, then obviously now is the time to start exploring how you're going to get access to that to enable you to submit your PowerPoint in the correct format. So, a lot of information. Do we have any questions? I'm just going to end the slideshow now. I'm going to stop sharing actually. Let me see, I've got to go that way. Stop sharing. Any questions? Stunned silence. No, Sinead. Good morning.
Good morning, Caroline. That you did actually cover the question I was going to ask, is how really are we going to include the references in the narration? So if I'm saying Marvick et al. 2002, I would actually say it just like that. Okay.
Yeah.
And what is your expectation, Caroline, for a 20-minute presentation? The amount of references, because a lot of my time would be taken up by saying reference.
Yeah, and that I mean, for if you were writing an essay, you would want one or two references almost every paragraph. So it's there's no difference. So you, just because it's a presentation, you wouldn't want to. You're not going to reduce the amount of referencing that you use, because that's what you're referring to. So yes, it does take a bit of time, but again, it's how you're presenting that. So if you're obviously, you're critiquing an evidence base, or you're comparing and contrasting, then it might be, and I'll just use our names just now, but you might just say, according to Stephen 2022, she believes that X. However, Scott Perry, actually states that we should consider this when we're implementing this infection prevention control practice. So on reflection and on balance, this is how, this is why we've decided that this improvement within our clinical area is of value, and it, we wish to take this forward, or whatever. But you would want a lot. I mean, in 20 minutes, you're going to still want a lot of references. An exact number is difficult to give you, but yeah, for every slide, I would want at least one or two.
Okay, and Caroline, in academic writing, I can't actually remember it. When there's a big long reference, say the national guidelines for cleaning, there is some abbreviation you can use that you wouldn't be using it all the time throughout an essay. I can't remember what it is. Can you recall what it is?
Et al.
No, not et al. There's some other abbreviation, and I was wondering if you could use that.
If it's any abbreviation, I'm not sure what exactly one you're referring to, but if you any abbreviation, as long as you've stipulated what that abbreviation is, and for the purposes of this presentation, I'll now refer to it as
right. Yeah.
Then you can just use that. You would then use the abbreviation for the remainder of your presentation, but obviously then you've stipulated what the abbreviation is going to be in your reference list. You obviously, if it's an actual reference, then you would have the name spelled out.
All right. Okay, thank you.
Yeah.
Sorry, Caroline, there was one other thing. Sorry.
Okay.
It said font 11, but font 11 is very, very small.
Is that what it says in the guidance?
Yes.
Interesting. Okay. if I'm being honest, well, obviously that's not correct, because that's from when it was an essay.
Right.
It used to be
Okay.
an essay. So no, font 11 is not okay on a presentation. I would recommend, and obviously it depends what information you've got on the slide, but an absolute minimum, I would say, is 20 point. So whatever font you use, you know, Arial or Public Sans or whatever,
Okay.
you decide. A nice clear, I would always go for a nice clear, crisp or sans serif kind of font, so that it's clear, but an absolute minimum of 20.
Okay. But the narration underneath
or
it.
28 is good, is probably better. But then if you've got a bit more information, you might reduce it, but I would go no less than 20.
And Caroline, do you expect underneath those presentation, underneath those slides, because the way I submitted in the formative, I had some narration underneath it. Do you expect some narration, some points, or would you, and I didn't get any feedback saying it was incorrect or it wasn't incorrect, would you expect just the slides and I will do all of the narration, or would you expect some text underneath each slide?
In the notes format.
Yeah.
Notes, that is up to you. I mean, I have notes. I always have notes on my presentations.
Right.
Which is why we always laugh and say, you know, when I've presented here this morning, if you were here at the very first, the display was the wrong way round for me. And at first, the first slide you saw would have said no notes, because that was my very first slide. I didn't have notes. But if you'd seen the next lot of slides, you would have seen I had all my notes. That's just how I deliver. So if that's how you deliver, that's absolutely fine, because that might be where your script is effective.
Okay.
That's kind of how I probably would do it, unless you're really super confident or very familiar with what you're talking about. But for this purpose, I would almost be inclined that my script for each slide would be in the notes, and that's what I'm kind of doing. Do you know?
Yeah. Yes, I
that
understand.
is also equally, if you don't have that there, again, it's how you feel comfortable. I'm not saying you have to have it there, but if you might have it on little cards that you just refer to, you know, below your screen. However, you know, I don't know how people prefer to deliver, but I would have it on my notes. So when I'm looking at presentation, but again, you've got to consider then, how does that look
yes,
on your narration. So if you can see your notes, that's not good. You just want the slide on the narration, so you might want to print it out and have it there. But yeah, I don't see any issue with having it in the notes section. They're probably just not referred. We don't look at it anyway. It's more how your narration.
Thank you, Caroline.
Thanks. Any other questions or?
Caroline, I don't know if you've seen,
you
put something in the chat.
Oh, okay.
How to access Turnitin. I think that might be a crystal.
Yeah, well, my understanding is this wouldn't go through Turnitin because it's not a written assignment. So it's actually hand-in, it's called, is my understanding. As I say, this is where it's, for us, it's challenging as well, if I'm being honest, because I don't have access to those platforms, because it's not got, you know, because we're at the RCN. I've not got the Coventry platform, but it wouldn't go through Turnitin as a written assignment would, to sort of look at the plagiarism element of it, but they can still assess, and they do still able to assess for the plagiarism element. Apparently, it's quite.
I think that was on the guidance somewhere, to put it in via Turnitin.
Turnitin.
Okay. Yeah, we'll put it through there. But yeah, I didn't first. Sorry, my dog's barking. Yeah, so I panicked about that first of all, and I managed to hand it in, but that's how you hand the assignment in, isn't it? So I just handed it in and went, oh, where's Turnitin gone? So, but if it's not required, then hurrah.
I will check again the guidance. the full guidance. In fact, maybe could just, let's see if I can just get it up in the background now, because this is when we should try and rectify, because we've got some time, haven't we, this morning? So this is what this is for. Let me see if I can get it up in the background. I had it there before. I just printed one page, the submission instruction page of. And I'll just do a research for the word Turnitin. Because to be honest, it's a bit like the Arial font 11. That we used to do a written assignment, and we have moved to, or Coventry, you know, we've moved to, it's been moved to a narrated PowerPoint. So I just wonder if there's just been a little misstep in, it still has that there, but it shouldn't.
Yeah, I do think it's an artifact from the previous cohort. I'm really sorry, but it is hand in. Everything's on hand in.
Yeah.
Okay. Lovely.
Yeah,
Thank you.
You wouldn't be able to submit the presentation through Turnitin because it's expecting words.
Okay. Well, that sorts that out. Thank you.
Yeah. Thank you.
I think Crystal was very kindly offered, Caroline, just to give some pointers for submitting for the group. She was going to pop it on the chat and then pop it in the discussion group for us. Not reiterating the guidance like you said, but just some, you know, some very short key pointers to help everybody.
Yeah. And as I say, everyone, hopefully, everyone who submitted a formative assessment should hopefully have now access to their feedback via the Aula platform on Coventry. So again, really obviously utilising that, any feedback from that, although I appreciate, you know, it's difficult how much feedback they'll have given, but they'll have got a sense of your submission, how your presentation style, etc. from that, and using that to really help you take forward the summative as well would be really valuable, or is valuable. That's why we do it. That's the point of a formative, is ultimately it's not part of your marks. So, but it's your opportunity to take that chance to get some specific feedback. And then obviously as well, in this sense of the narrated PowerPoint, is giving you that opportunity of a bit of a practice of, because some of you maybe do that kind of thing regularly, but some of you will never have done a narrated PowerPoint and hardly ever even use PowerPoint, let alone, you know, doing that as a narration. So the formative really hopefully just kind of gave you that chance to have a bit of a practice and an opportunity to try it and trial the submission and iron out some of those issues before it comes to the summative.
I don't know, Kerry, have you got a question? I just spotted your cameras on. No.
I had some tech. I'm not very techie savvy. The day of handing in was probably the most stressful day in my life, you know, when you're trying to submit, and they struggle to hear my presentation, but my end, it's saved as an MP4.
Okay.
So I don't know what's happened, but I use my work laptop. So I was on the phone to the IT guys for both Coventry and within my own organisation to try and get the firewalls unblocked. So I've just asked Crystal for a little bit of help with it. If I'm being honest, it's more because, you know, I really struggle with it. And to be honest with you, my feedback on this course would be I would have felt less stressed just doing an assignment. You know, because the 20 minutes is you know, I'm struggling.
Yeah.
You know, with kinds of that side of it, you know, the volume of like you say, you know, references and things that need to be included.
Which would be the case
all that into a 20-minute presentation is proven difficult. And I don't know whether anyone else is struggling with that. So I just think I'm probably old style. It probably would have just been easier to do an assignment, to be honest with you.
Possibly, but I guess you know, it is unfortunately what it is. The assignment has been moved and changed, and that's what it is. But everyone has their different weaknesses and strengths, I guess. So some people might actually really quite like this sort of style of doing a presentation, and would have really struggled with like, although it's obviously still academic, but in terms of the actual academic writing, some people still really struggle. We had issues then, people saying, does it have to be an academic assignment? So, I think unfortunately, when it comes to doing something that's with academic trade, there is an inevitable stress around it, isn't there, around it doesn't maybe quite fit for me, or it fits for you, or so I appreciate, but anything that we can do is hopefully to support, and again, even reaching out to Coventry. But the formative at least allowed you to have that opportunity to try and see that you did have those issues. Again, that's
I still don't know what I've done wrong though, I'm being honest, because my end it's saved as an MP4, so it might just be a firewall issue.
Maybe. So they couldn't hear it at all. All right, okay.
I think I've got do you mind me like telling you what happened here, or do you want to go into a breakout room?
Yeah, can I go into a breakout room? Is that okay?
I'll open that. I'll be back.
Brilliant, thanks. Caroline, there's a question in the chat from Chenga. Can we pick 2 service improvements such as ANTT and hand hygiene for the topic catheter-associated urinary tract infection?
I mean, I guess it's up to you. I would be inclined to narrow it down, because I think sometimes if we try and do too much, we don't get the depth and the analysis and the real meat, for want of another way of saying that, because then you can't get into anything deep enough, and you can't get into the exploration around that and really discuss the concepts. So I would be inclined to narrow it down to one or other.
I'm with you on that, Caroline, as well.
Because you tend to just brush over things, or don't mean that in this, but you can only touch on things if you try and do too much. Whereas really, for your assignments, whether it be level 6 or level 7, you need to get into the core of it, and you really need to discuss it, and you really need to analyze it, and you really need to demonstrate that you've given it good thought. So yeah.
I think it's easier from my point of view as well. I think it's easier to pick one, because otherwise if you pick 2, you're then thinking about balancing out which one I'm talking about more, or am I talking about them the same? So if you pick one, you haven't got that worry.
No, exactly. Yeah.
There's nothing else in the chat. I don't know about anybody else with questions.
Or anyone had, their feedback that they would, I mean, you don't need to share it specifically, but anything in your feedback that you think you got that you sort of think would be helpful to others, or that you want to bring to the table, because actually other people might have had similar issues. So for example, the MP4 and the listening, that is interesting, because I don't know how. I'm like, oh, if you've done it as an MP4 and you've got a narration, how can't it be heard? Yeah. So but yeah, if anyone's got anything that they want to share or bring to the room today, that's fine. Or not.
There's a question for Crystal in the chat. Can you check what happened to my formative 2, as I submitted it, but they said they did not receive it? And that's Annalisa.
I'll have a look. I'm just going to see what's happening, because Carrie keeps getting kicked out of the breakout room. But would it be convenient to give you a call today, anytime, and I can just explain? Okay, I've got your... Okay, great.
Thank you.
And then Annalisa, I'll check that now.
Thank you.
Thank you, Crystal.
It's okay.
Isn't this technology wonderful?
Great when it works.
I mean, doing a PowerPoint presentation, having been an infection control nurse for years, it's something that I've kind of done for years. And I think some of the, I'm sure some of you will have done presentations as well in the past. So it's just, in some ways, just think of it that it's similar to that. The only thing you're adding in, and if you notice when I go through my slides, I've often got some of the references in the slides. Some of them will be at the end. It's just about, you know, finding the right point to put some of those references in. And if you think about the one that I did yesterday, which was on the leadership thing, when I talked about there was 3 slides that were about the leadership, particularly infection control. And when I started off, I said the name of the person. I didn't do the et al, I'll admit. And then I gave just really very, very briefly that it was a qualitative survey that was done in the United States and that kind of thing. So you can get those kind of things in there quite quickly to show that you're doing that critical analysis of them. And for some example, for some of the ones that we did yesterday, the study that was done in Ireland would probably be extremely similar to the UK. The ones in the US, still quite similar, because their IPC is very similar. But if you were going to take a piece of literature that's come from a more developing country, then you would definitely want to sort of comment on that in there. And if you're using literature older than it says, because they're seminal pieces of literature, don't forget to justify why you're using it. Just say it's a seminal piece.
No, it's a really good, I think that's it. I think because we add the word assessment, there's instinctively more anxiety, obviously, around it, because there's the nervousness around what that might or might not mean. But yeah, and I think that's the other thing, doing it as a PowerPoint, although I fully appreciate it's not everybody's preference, I think it does help develop other skills, those kind of, you know, that might be beneficial to you either in your role now or moving forward as well. So it's trying to sort of push that wee bit out of the comfort zone to try and develop some of that as well.
Lovely. Annalise, I can see your communication with Crystal. I guess Crystal will come back to you about the best time that she can give you a little bit of support with this.
Yeah, thank you, guys.
And obviously you still do have Coventry IT as well, people to use for the support around this. And don't forget, you've got Coventry Library there for the support. And for any of you that need any particularly different support around studying, then they do have that support available from Coventry Library. So do utilize that if you need that support, even though this is a PowerPoint, not a traditional essay.
Yeah. Okay. Well, hopefully it's giving you some food for thought, obviously, just around that sort of structure today. And obviously, again, if you're thinking about examples, I know that Winnie from Coventry has a teaching example available, and I think that's it's available on their platform to view. So again, if you're sort of thinking, well, what was that bit again about? How do I maybe talk about the references and how do I get my evidence in, as very well highlighted by Chris, obviously, but equally going back and revisiting that, or visiting it for the first time if you've not looked at it already. Again, that, you know, is direct from Coventry. That's their example of how you can meet the requirements for the narrated PowerPoint. So it's really worth a watch.
Just a little reminder of your submission date. I'm sure you all absolutely have that crystallized in your minds. It is Thursday, the 17th of April. So that's the day before Good Friday. So before the Good Friday bank holiday. So I don't think many of you will forget that date. And as Caroline said, I think it was 6 o'clock. You said, Caroline, wasn't it?
Yeah,
the cut-off time?
On the guidance it says 1800 hours.
100 hours. So yeah, make sure that you have it in by then, which would be great.
Good.
And
okay, well, if there's no other questions directly for myself, just I wish you all good luck. And I'm sure it'll all be grand. Yeah, and I feel your pain, because we've all been there. We've had those things to do when we've done our own training and assessments and such like. So I do feel your pain, but I'm sure it'll all be well. And worst case scenario, there's always the option for a resubmission as well. So that does not that hopefully anyone will need it, but just it sometimes helps me in my head to know, okay, I want to get this the first time, but if something doesn't quite go right, I've got another shot. So
yeah,
good. Okay, well, and thank you very much.
Thank you. No, thank you, Caroline. I think that's been very helpful. I'm seeing people saying thank you and some thumbs up and everything. So thank you ever so much. And also do keep in touch with each other on the discussion page.
Yeah.
So if any of you are having problems and you come up with a solution, it would be really helpful if you post that in the discussion page in case other people are having that same problem as you. Please use that to help each other, because as we said, we can't submit, so we don't have that experience of submitting it. So you're helping each other if you've got answers to questions. Thank you, Caroline.
Well, thank you. Nice to see everybody, and yeah, I wish you all very well, and I'll see the team soon, I'm sure.
Brilliant.
Great.
Thank you, Caroline.
Thank you. Bye-bye.
Bye.
Thank you.
Okay, we're going to take a break now. You've got a nice 20-minute break because we started early, so we finished a little bit early. Yeah, Sunday, that's absolutely fine. We're going to start at 11 o'clock. So if you could be back ready to start at 11 o'clock, I'd be really grateful for that. Obviously, do the usual, pop your cameras on or let us know in the chat that you're there. And the rest of the group will be joining us while we're in the break. So see you in about 15 to 20 minutes. Thank you. Okay. So that's brilliant. Okay, this is just the session content and what we're going to cover today. So it's going to be about raising concerns and about having the difficult conversations. And I'm going to give you some frameworks for difficult conversations and then a little bit of group work with difficult conversations for you to practice on them. So this is going to be a little bit of a whistle-stop tour to speaking up. I would imagine that a majority of you, if you work for the NHS, have had some speaking up training anyway. So just wanted to cover what are the benefits of a speaking up culture. If we get it right, we reduce our harm and costs. The safety is absolutely obvious that that's a key part of it, but not just for the people we're caring for, but for the workers as well. And it makes a better organisation. It means that we do a lot better in our performance, and it means that we're more likely to keep our staff. So there's some really good reasons why we should encourage speaking up and encourage it as a culture. Now, just want to do a little bit of a reminder on our professional responsibility here. And this is the NMC code here, which is very clear that you have to speak up if there's a risk to patient safety. And if you're in a position to support others to raise concerns, you should be able to do that. And if you're that person in the position that you should be taking the action, then it's important that you take that action there. It's the same for the healthcare profession code as well. The NMC and the healthcare profession code are both very similar on this. But there's lots and lots of reasons why people don't speak up. And most of them are set out here. People have a fear of being victimised. And that is particularly so for the global majority of workers. And if you look at some of the differences over the years that we've seen in data, you will see that the global majority of workers are less likely to speak up and have that greater fear there as well. People don't want to be seen as troublemakers. And people don't know whether it's serious enough at the time to be able to do this. And there's always that fact that some people will leave it and hope that somebody else will raise those concerns so that they're not the one that that has to be the one that speaks up. In the 2023 survey of Freedom to Speak Up guardians, 2/3 of them said that people thought that they didn't believe action would be taken. But the Freedom to Speak Up guardians are now reporting that they do feel that more people have the confidence now around that speaking up. Evidence from England here from the NHS staff survey, and this is the 2023 staff survey. And the percentage of staff who would feel secure raising concerns was at a 6-year low. The orange line there, orangey red line, is medical and dental. And you can see that, you know, that's particularly notable how far that line has gone down in the couple of years prior to that. But I think it is overall reassuring that 71.28% of staff would feel secure raising concerns. I think the ambulance service is another notable one there, which they've always been the lowest out of the healthcare groups with the staff survey about their security around raising concerns. And in the staff survey, about 57% of staff were confident that their organisation would address them. So in some ways, that's nice to think that over half, but that's almost half of staff in the NHS felt that if they said something, they didn't have the confidence that it would be addressed. Now, let's look at speaking up and what happens when it really, really, really goes wrong. Now, I'm guessing most of you will have heard of the Mid-Staffs inquiry, the Francis inquiry, which is at Mid-Staffs Hospital. And I know it's quite old now, 2013, but that's where the culture of speaking up has really been pushed forward from that point. And the addressing the whistleblowing and the Freedom to Speak Up guardians in England, they were developed following the Francis's recommendations in his report. So what was happening at Mid-Staffs was there was a lack of basic care in many of the wards and departments. Patients were being left in soiled clothing and in bedclothes. They weren't having assistance with feeding and drinking. And staff were treating patients and relatives with indifference. And there's one very notable quote in there where one of the relatives said she saw a patient drinking out of a flower vase because they didn't have any water near to them. And the report says that it seems to have arisen because the trusts were focused on meeting financial targets and satisfying the requirements they needed at that stage to attain foundation status. They were more focused on that than they were on caring for patients. And I think this is a salutary tale for us as we head into the next couple of years within the health and social care system, where we know there seems to be a drive at national level for us to cut our funding and our finances. So we must be really, really aware that we don't make those cuts to patient care. Gosport is another really interesting one, and the report was done in 2018. But a staff nurse first raised concerns at Gosport in 1991 about the prescribing of opiates for patients. And it was concerned about high use of diamorphine in elderly patients, and a lot of patients that died very shortly after being given highest doses of diamorphine. And between that 1991 and 1992, a number of nurses raised concerns about the prescribing of drugs, but there was a culture of doctor knows best, and this continued for a significant period of time. And it's thought that 456 patients died where opioids had been prescribed and administered without clinical justification. The Royal College of Nursing did support the staff in speaking up in this case, and the inquiry into this concluded that the hospital had the opportunity to rectify practice, but in not doing so, they lost that opportunity. And 22 years after this, that's when the panel was set up to look into this. So massively lost opportunity and massively lost life. And then bring it a little bit more up to date here. It says 2022. These aren't infection control examples. I will give you an infection control example later on. But this is East Kent in their maternity and neonatal care. And a midwife spoke to the inquiry there and told them there was a fear of speaking up. Instead of consulting staff and discussing how issues could be improved, they were told what to do and viewed as negative if they proposed any alternatives. They disempowered staff from speaking up at a very senior level, and it was hard to voice opinions without them being taken the wrong way. Now, one particular member of staff sought advice from a professional body about the culture of bullying and intimidation, and they were advised against speaking up in the interest of patient safety because of the risks this posed to their further career prospects. So when you see this written, you know why it's really, really difficult for people to speak up. So that's what happens when it goes wrong. But what do we know about how it should look like? And this is what a good speaking up culture should look like. That speaking up is business as usual. Addressing barriers to speaking up before it gets raised that you have a problem there. You always want leaders who are able to listen well and respond well. And for that needs leaders to be accessible. It needs them to be out and about in the clinical environment. And it needs the leaders to show that they are responding to people that speak up, and change can be demonstrated. I think I mentioned yesterday about our boards that we used to display outside of my wards at Western Hospital when we had the so many days between MRSA. We also had on there what the patient's feedback was, the you said we did. And in the staff room, we had up there from the staff point of view, you said and we did. So we were able to really very clearly show staff that we were listening to them. A key reason why people don't speak up, as you've already heard, is about them feeling like the blame will be put on them. And a really good speaking up culture won't do that. They'll focus on the issue and they'll focus on not blaming. And the person speaking up will be involved in it, but they will not be the key person that gets involved in the response to this. So if you want to speak up, this is some really good advice for you. Be clear and specific about what are the facts and what might be your views and your feelings. It's not wrong to speak up about your views and your feelings, but it's really helpful if you can put that, not distance between them, but make that clarity about what you've witnessed and what you feel about it. Every trust will have, or organisation will have, a policy about how to speak up, and it will usually start with speaking up to your line manager or the person who's responsible for the matter. Check your policy for who else you can speak up to as well. There's a number of ways that you can do it. It can be in person, it can be by email, telephone, or by any other written method as well. And you have a choice if you want to speak up about how this is done, be it openly, confidentially, or anonymously. And any of the ways that you want to do that are absolutely fine. It will be anxiety causing for you. And don't worry about that, because it is normal that you will feel anxious or nervous if you have things that you need to raise. If you're in a leadership position at all, then positive leadership behaviours can really help people to come to you with these problems. I always tried to stand by this, and with any feedback I got, I always made sure that I said thank you. If I needed clarification, I would ask for clarification. But if somebody comes to you with a concern, and if you start being negative about it, that will really, really put a dampener down on that person's experience, and they may well not speak up again. Listening well, protecting the person's identity is quite an important thing in these circumstances. And one of the examples that I gave you, it was the Francis inquiry. They knew the person that had spoken up, and she was made to feel really, really uncomfortable about what she'd done. People that she'd worked with for a long time started saying to her, are you going to be the next person? Am I going to be the next person that you're going to be complaining about, etc.? So clearly, when she'd spoken to senior people, they had made other people aware of who had raised that concerns. Be aware of the barriers, which we've already mentioned. And I think this is a really, really important one. It links back to the leadership that we were talking about yesterday in the infection prevention and control. Feedback and celebrate when people do these things, because it's the type of practice that you want. And we've already mentioned there about the demonstrating the difference that speaking up has. I used the speaking up policy as a DIPSI when I was working at the Bristol Royal Infirmary. And this is going back a few years when variant CJD had been had suddenly come into the limelight. This is the mad cow disease that some of you will remember. I'm sure some of you will have only been very young when variant CJD was first identified as a problem. But it was a novel microbe, which we didn't know very much about at the time. But what we did know was that our standard procedures for decontamination, for sterilising in an autoclave, may not be effective against prion proteins, the causative agent of CJD and variant CJD. What we knew was the washing process was one of the most important things that needed to be done to make those instruments safe. So the government invested a lot of money in organisations. They gave us quite a few million, in fact, and they were to be for new instruments and for our sterile services departments to upgrade their equipment. Now, our sterile service department hadn't been upgraded for a number of years, so it did need a significant amount of new equipment. But we also had instruments in a number of our sets that were damaged, that had scrapes in them, that they were struggling to get the rust off of them in some circumstances. And we knew that if we had damaged instruments, they were harder to wash properly in a washer disinfector. So my view as the DIPSI, and my microbiologist, Bob Spencer, his view as the microbiologist and as the decontamination lead, was that we needed to invest in both areas, both in instruments and in new equipment. Our estates department, in consultation with the finance department, decided that all the money was going to go to upgrade the sterile services department. Now, bearing in mind that at that point in time, I was the chair of the Infection Control Nurses Association, and my microbiologist, Bob Spencer, was chair of the Central Sterilising Club. We knew what we were talking about with this, and we knew that this was wrong. We needed to deal with the instruments as well. So we went to our executive lead initially and had a conversation with our executive lead about what we should do. We both went together, and she actually suggested that we write formally to the chief executive and raise it as a concern, which is what we did. We had a very good response to it. The chief executive responded immediately, and lo and behold, some money was found from the money that's always put back, the reserve that all organisations have in case something goes wrong. Money was found from the reserves for us to have our upgrade of instruments as well. So a win-win situation all round, and a really good experience for me about speaking up. Now, it doesn't always work as well as that. This is an example of IPC whistleblowing, which is in the public domain, and an inquiry that's currently happening at the moment. It's the Scottish Hospital inquiry that's investigating the construction of the Queen Elizabeth University Hospital Campus Glasgow and the Royal Hospital for Children and Young People and Department of Neurosciences in Edinburgh. So 2 brand new hospitals. And in these brand new hospitals, after they moved in, they had problems with incidences of infection in the hospital: Stenotrophomonas multifilia, Klebsiella, Pseudomonas species, Serratia marcescens, and Aspergillus, environmental organisms. And what the microbiologists here had been raising were problems with the safety of the water, drainage and ventilation systems, with non-compliant taps, with high total viability counts of bacteria in waters, inadequate ventilation filtration in the bone marrow transplant unit, inadequate negative pressure isolation for patients that needed that protection, and inappropriate placement of at-risk patients. So nothing more than most of us as infection control practitioners would be concerned about in our practice. But you can see here, I'm not going to read this out particularly, all that's on the slide, and I know it's small writing. Just out of interest for those of you that are doing the assignment, this is 22 gauge writing, not 20. So that would give you an idea about what 20 would look like. And these were 2 very, very senior people. They tried to speak up, repeatedly tried to raise concerns. They were intimidated by senior employees. Tone of the meeting set, cut short introduction, and shouted at and sworn at by a manager in front of colleagues. I think this shows the extreme of what people experience when they try to whistleblow. I would hope that most people's experience is not quite as severe as that. So speaking up, there are a number of places where you can go to where people will help you. In England, you've got the Freedom to Speak Up Guardian's office, and in organisations you will have a guardian and you will have a lead for this. Scotland has an independent national whistleblowing office. In Wales and Northern Ireland, there are places that you can go, but there's not particular guardians or whistleblowing offices. You've got your professional bodies, you've got the regulators like the Care Quality Commission, Health and Safety Executive, you've got patient organisations that will sometimes help you, and you've got other charities and organisations, for example, Speak Up Direct, Protect, and Whistleblowers UK. So I am going to stop sharing at this point. Stop sharing. Okay. And I am going to ask Julia to pop online, if you don't mind. You don't have to put your camera on. But Julia, do you have anything that you think would be useful to share with the group about, from your role as a Freedom to Speak Up Guardian, about how to get this right?
So I'm not the Freedom to Speak Up Guardian, I'm a Freedom to Speak Up champion. So we have a guardian who oversees it throughout the company. And then what we have is locally, we have Freedom to Speak Up champions. And within our, we have 9 hospitals, and we have as many people, sort of as many people who want to be interested in doing it. We're very keen to recruit more. The problem that we have is that I think because it's a relatively new concept, it's senior management heavy, which we've tried to deal with and actually tried to get other people involved. And it's really difficult. We find that, ideally, I would like nothing more than it to be, to have HCAs or, non-clinical admin, sort of people in junior admin roles to do it. But they're very reluctant to do it. We've done a big campaign of talking about, explaining what it's about and how people can be involved. But yeah, there is a lot of reluctance to do that generally. So at the moment, it remains sort of senior management heavy, but at least it is something that we actually do have in place. I think the absolutely fundamentals are that you have to have in place, and people have to feel confident that you are working within a no blame culture.
Yes. That's really, really helpful, Julia. So my takeaway messages from what you've just shared with us there is the no blame culture is important right the way through the organization. And if I'm correct, there are algorithms that you can follow through around this as to if somebody's deliberately breached a policy. When you find this, then that's a different situation. Most people don't come to work in the morning to do something wrong. It's usually, something incidental that's made it happen to them. And the other takeaway message, which I'm sure Julia will support, is go away and have a think about whether this is something that you would like to do.
Yeah, sorry, I lost you there a minute. So, Chris, I lost the sound. But yeah, and actually, yeah, there are processes. You said about the algorithms. We have sort of like a flow chart. I'll be perfectly honest with you. Most of the things that we do deal with are don't require to be escalated. Do you know what I mean? So very rarely do you actually come across something as a freedom to speak up champion, where you're immediately kind of taking that outside of your local, your local hospital, sort of taking it to the national group. And I think that's what people think it's going to be, but it's usually not.
That's really helpful as well, Julia. So if one thing comes out of this, if one person signs up to be a freedom to speak up champion in their organization, we'll have done a good job of selling it to them, won't we, Julia, with a bit of luck. Okay.
Yeah, it is. I mean, I think it is very good because it's I mean, I'm the safeguard
I think we lost you then, Julia.
lead for the hospital, very close partners. So
yeah,
and they've they're very close partnerships, those things. And interesting enough, I've had people come to me to raise a safeguarding concern, which actually really falls within the freedom to speak up, rather than it, because I think sometimes it's people are afraid, think that they've got a safeguarding concern, and it's not, but it is a concern. And therefore I think that the freedom to speak up side of things and the champions enables you to to support people through that process.
That's really helpful. Thank you, Julia. Does anybody have any questions about the speaking up bit before I move on to having the difficult conversations? No? Okay, we're going to try and start sharing again now. So this could be the fun bit, starts again. Okay, I'm hoping that you might have the right screen up now.
Yes.
Fantastic. Getting it right, luckily. Okay. So now we're moving on to having difficult conversations. And the types of difficult conversations that we have at work are about all these things. These will be familiar to you guys, whether you've been the one that's been receiving the difficult conversation yourself, or whether you're the one that's having the difficult conversation. But the reason that we include the speaking up and the difficult conversations in this course is because with infection prevention and control, if you're having to address practice issues, then very often it's about the conversations that you have that make the difference. So clinical conversations at work sometimes happen, but more than often it's about these. So we're hoping you don't have to have too many of these conversations in your workplace. But they are hard to have for a number of reasons: lack of confidence, fear of rejection, hurting feelings, unclear on what you need, or traumatic past experiences. I'm going to share a difficult conversation that I had that was particularly challenging for me. It wasn't an infection control one. It was when I'd first taken over as the chief nurse at Western General Hospital. We had to make people redundant within our governance team because we had a larger governance team than the organisation could continue to support. And to be fair to me, this piece of work had been done before I joined the organisation, and then it was left with me to implement this review of the governance team. And I had to tell one of my governance team that they were being made redundant. There was somebody that I hadn't worked with for very long, but I knew a little bit about them, and I knew that they'd only recently taken on more money with their mortgage so that they could have an extension done, and they'd worked at the organisation for a significant period of time, and it was part of their life, as a number of their family also worked there as well. And I knew this conversation was going to be really, really difficult. So I actually went home, prepared myself for it. I only lived 10 minutes from the hospital at that point of time, and I knew that I had to go into that conversation really, really well prepared. I went in being as compassionate and empathetic as I could be. The conversation went the way that I anticipated it would, and the person got really, really angry with me, and they actually walked out, which was fine. I had to let them do that, and then we had to resume the conversation at a later date on it. But if I hadn't been prepared for that, I know it would have gone even worse than I still feel it had. And you can probably guess that it's had such an impact on me that I don't really like talking about it, but it's an example that I can give you about how it made me feel really, really bad about what I was doing. But if you do prepare for it, it does make it that little bit easier. And I'm going to share with you a couple of frameworks that I have found quite useful in my practice. The first is the COIN framework, where you take the context, you talk about the circumstances, the event, or the issue that you want to discuss. You take the observation. Now, this is where I think with having a difficult conversation, it's really helpful if you can be specific and give descriptions of what has happened. It's no good going into a conversation saying, well, I want to talk to you about your hand hygiene. It's not very good, unless you can give some very specific examples about when, how, and why. Talk about the impact, how that event or issue that you've discussed affects others in your team or organisation. And then it's really important to have a next steps. Don't just leave the conversation about, well, your hand hygiene's poor and I want you to do something about it. You need to be very clear about what you want that person to do, the change in behaviour or the next steps going forward. So that's the COIN one, which I think is a very, very easy one to remember. And an even easier one to remember is the EASY, and that should be 3 E's there. So I don't know why it's showing ESOP. I think that might be the spell check that's changed it for me. It should be the EEE, easy framework for difficult conversations. So the 4 E's, similar to the coin, but the evidence, what have I seen, heard or read that could be shared? Expertise, what does my training and experience tell me about this? E for empathy, what might the other party be feeling right now? What can I ask them to find out more about this? And then E, exploration, apart from my current goal for this meeting, what other options could I be open to? So an easy framework to think about the difficult conversations. Now, I'm going to get you to go into groups now. And Crystal, if we can go into 3 groups again now, please, for 10 minutes. In your groups, I'd like you to discuss any difficult conversations you've been involved in. Did you use either of the frameworks? Did you use another frameworks? What could you take away from these frameworks for any difficult conversations? Or if any of you has a difficult conversation in that group you need to have, use the group to test out how you might do it. So you've got 2 options. Think about the conversations that you've had and what you've learned from it, or think about conversations that you need to have and test them out how you might do that with the group. And whilst infection prevention and control would be ideal, if you can't think of any infection prevention and control ones, then you can use any examples for me. So I'm going to try and stop sharing now. It says.
How long do you want them in there for, Chris?
Oh, can we do 7 minutes, Crystal? That okay? That'd be lovely, thank you. Hopefully you're all clear on what we're going in to do with that. Like I said, conversations you've had or conversations you need to have. There's just to finish off with some useful phrases and some tips for you. These can be helpful phrases because they're quite neutral. Something I'd like to discuss, a bit sensitive. May I just describe how it looks to you? So you're already warning people that this is going to maybe a difficult conversation. Let me make sure I understand what you're saying. How do you feel about that suggestion? So like I said, some very neutral ways to speak to people. And some other useful tips here. Don't put off the difficult conversation. It will only get harder. And I liked this when I found this. Don't be afraid to use a do-over. So if the conversation isn't going quite the way you want it to go, say something along the lines of, that didn't come out quite right. Can I try that again? I'm concerned some of the things I said aren't helping. Can we start over? Things didn't really go the way I was hoping when we talked. Could we rewind and try having the conversation again? So really useful ways if it's going in the wrong direction for you to either stop it there and then and restart, or for you to stop and then restart on a different day. Don't use irritators. I expect you've all had this said to you. With respect, I hear what you say, which often means people aren't hearing what you're saying. Try to be on common ground as much as you can. And if you get criticism of you, accept it if it's on topic, but keep the person on topic. Just say, thank you very much. Don't ask for any detail. Don't get defensive in that situation. So just a quick summary of what we've done in this session. We do need to raise concerns. It's part of our accountability. And if we've got the right culture in place, we know that it improves patient safety and it makes it easier for people to speak up. Be aware that speaking up can be harder for some groups compared to other groups. And whilst we're seeing that culture change towards supporting people, it's still hard, but there are people that are out there to support you. And if you think you've got to have a difficult conversation, prepare for it. And the longer you put it off, the more difficult it's likely to become. So I'm going to stop sharing at that point. We are now going to go and have a very quick break. So if I can give you 7 minutes just to have a comfort break and grab a drink, and if you could be back to restart again for 12:05, that would be fantastic. Start recording again. Okay, so your last talk session, we are going to talk about assurance and regulation in the context of infection prevention and control. So we're just going to take a really quick look at legislation and regulation and guidance as it applies to IPC. We're going to look at codes of practice and the regulators, and we're going to look at how you provide assurance within your organisations. So just a really quick thing to start with, I'm not going to dwell on this. There's a difference between legislation and regulation. The law is based on and meant to carry out a specific piece of legislation, such as for the protection of the environment, and regulations are usually enforced by a regulatory agency. So the law is the legal obligations or restrictions that are enforceable by law. Just a reminder that we do have devolution. So the laws may well be different for England, Scotland, Wales and Northern Ireland. I think the majority of you on this course are from England, so most of what applies will be the English law for you. But just a reminder that if you are, or if you do work across any of the other countries, you may have to look at different legislation for those areas. Again, a quick reminder around our professional regulatory requirements: Nursing Midwifery Council, compliance with the NMC code, and a requirement to work safely. Within the Health and Care Professions Council, standard of conduct, performance and ethics, reasonable steps to reduce the risk of harm, and not do anything or allow someone else to do anything which could put the health or safety of a user, carer or colleague at unacceptable risk. Now, the regulators do take actions, and these are infection prevention and control related ones here. The top one, dentists struck off, reusing single-use instruments and not changing gloves, and the practice manager struck off too. They must have been registered on the Healthcare Professions Council as a dental nurse, I'm guessing. The Finchley GP there, 30 patients contracted hepatitis B, using needles and clinical waste not disposed of. That was a GP that wasn't doing normal general practice work, but had moved to doing acupuncture, and it was acupuncture needles, but he was still registered on the General Medical Council, so was reported to them and was struck off. 2014 here, a Birmingham nurse that was reported as no apron worn, didn't remove gloves and clean hands after an MRSA patient. I'm guessing it wasn't just that. I'm guessing there was more to this one than that one. 2015, the Shetland nurse struck off for falsifying data, and some of that was infection control audit data that they've been submitting but not having done the audits. And this last one here, Nottinghamshire dentist, hepatitis C. They tested 4,526 patients and 5 of them were found to be positive. And you can see there that some of the issues that were raised: not changing gloves, not new surgical masks, not sterilising instruments, etc., etc. Now, I just want to show you a couple more relating to the NMC that are more recent ones, in case any of you need to use any of these. If you want to use them as references in your assignments, or if you want more detail, I have the names that I can let you have. The top one, these are all infection control related. Nurse administering Botox that resulted in the patient getting an infection, and she obviously didn't have the right facilities to be working in. She used a parcel as a table for her instruments during the procedure, not an instrument tray. Attempted to squeeze an abscess on the patient's forehead when it was not appropriate to do so, and allowed or encouraged the patient to increase the dose of flucloxacillin and to use out-of-date ones. So that's related to both IPC and antimicrobial use. The next one is a registered manager from a care home who, this was during, oh no, this one isn't during COVID, this is post-COVID. They were medical slimming clinics. And when they went in, they had no infection control policy, No members of staff had received infection control training, no cleaning schedules in place, no supplies of sterile gloves, no hand washing facilities anywhere. And this was the Care Quality Commission that initiated this action, and they were referred to the NMC and struck off. The next one is a nurse in a nursing home in Lancashire that failed to follow IPC guidance during COVID. They were going in and out of isolation rooms without changing their protective clothing, and they were caught outside of work in their uniform. The Belfast nurse wasn't following isolation and hand hygiene guidance. There was more to it than just this, but that was part of the reason that they were struck off, was the infection control was mentioned within it. And then there was a nurse in Cumbria who again was found wearing uniform outside of work and wearing a coat over their uniform inside of work, and this was in a registered care home, and they had an interim suspension order. And the last one here I think is a really interesting one. Derbyshire nurse was struck off for spreading disinformation about COVID on social media. And because they were a registrant, they were putting information on there that COVID wasn't real, that the PCR tests don't really test for COVID at all. So we're not looking for COVID, we're not detecting COVID, we're getting flu, that the vaccines don't work. She was referred to the NMC and she was struck off. So some, really key examples there of what the regulators from our professional point of view will do. We have the MHRA, which is the Medicines and Healthcare Products Regulatory Agency, and their role is around making sure that the devices we use in healthcare are safe. So the syringes you use, if you have a sterile services department that's supplying to other organisations, they will have a role there in making sure that what they're supplying to others is safe. And you can see the legislation there that it relates to. I'm sure you're all aware of the MHRA and what they do around medicines, but the healthcare products are important as well. This is a recent regulatory action that the MHRA took, and it was around Burkholderia capacia infection associated with contaminated eye gel. And you can see there that there's 52 cases, so it was an outbreak, and one person potentially died as a result of it. They are linking the death to the infection and the contaminated eye gel. So what the MHRA do is they will issue a safety notice. They will enforce a recall of any specific products and batches that might be contaminated. But in that safety notice, they also put a recommendation to not use those eye gels in individuals who are at increased risk of infection, and you can see the ones there, like severely immunocompromised in hospitals or patients awaiting lung transplant, and a requirement for people to report any further incidents from there. So MHRA has a role in the products that we use, recalling them when necessary and issuing safety notices that we may well have to implement. If you think back to Dinah's lecture that she did around the tongue depressors that cause the infections in the neonatal unit, the MHRA were involved at that stage in issuing immediate notice to us to stop using them. So that's where they all link into the infection control area. Health and Safety Executive. Across all the 4 countries, we have the Health and Safety Executive, and the legislation that underpins the role, you all know the Health and Safety at Work Act. The control of substances hazardous to health applies to microorganisms, and all microorganisms are graded according to their hazard level. So that's why, for example, if you're sending a specimen from somebody with query tuberculosis, you have to put the biohazard label on it, because in the laboratory they have to handle that in a different way to how they would normally handle sputum specimens, because they do it in a fume cabinet, so they've got the extract from it. So that's where the health and safety come in with our normal day-to-day activities. But they also come in where they can take people to court around healthcare associated infection. The top one here, hepatitis C. It was a new staff member who'd worked at the trust for 3 months. They were an unregistered member of staff, and they'd been trained to take blood. They were told to take blood, but they weren't told the infection status of the patient, and the patient was hepatitis C positive. They took the blood, but they had difficulty reaching the sharps bin, so it wasn't by the side of them. They put the needle on their work surface. The patient was bleeding, so they reached for tissue, caught the needle on their wrist. The employee wasn't being supervised at the time. The risk assessment for it hadn't been adequate. There was no training on the controls, i.e. the sharps being within reach, and there was no oversight or monitoring of safe practice. So no monitoring that the correct procedures were being carried out with blood taking. The next one down is a Legionella in a care home in Essex. And 2 patients died. Oh, sorry. 1 patient died from this, 1 resident. And they'd allowed Legionella to persist despite various warning bells. So they'd had the increase in the Legionella levels, but had done nothing about it. All of this is in the public domain, so I'm not telling you anything that is any secrets here. Nobody had a grip on the risk, and they showed a lack of remorse when one resident died. The initial fine against them was 3 million. They appealed and it was reduced to 1.5 million, but a significant amount. And the other Legionella there is in Basildon University Hospital. They had 2 patients died from this, and it was linked to shower heads and thermostatic mixer valves, which were not being cleaned. Hence the importance of having your water and your ventilation systems under scrutiny and under assurance within your organisations. So there is legislation that relates to infectious disease. The first one is the Public Health Control of Disease Act. And this is where a Justice of the Peace can order someone who's infected and may present significant harm to human health to be detained in isolation. So I've only ever heard of this used once during my career, and it was with somebody who had multi-resistant tuberculosis, multi-drug resistant tuberculosis, and they were non-compliant with their medication. So the judge ordered them to be isolated. They can order health measures in relation to premises. So this is where your local authority will be doing their food hygiene inspections. And if they find significant risk, then a judge may be able to order closure of those premises or restriction of activities. The bottom one is about the requirement to notify. Those of you that have worked in general practice will probably be aware of this one, because I suspect you've had to get involved in this. But if you send a specimen off for somebody and they have a disease that's under these notifiable regulations, for example, like salmonella, tuberculosis, variant Creutzfeldt-Jakob disease, you have a duty to notify that, or to notify contamination in a dead person as well. And there are forms that get filled in that then get sent off to be scanned. And the reason for this is to determine whether there is any further public health action that may need to take place. Link this back to the regulatory action on the healthcare workers, where there was things like hepatitis B and hepatitis C. When that was notified, they would have done a look back exercise to see where these people's got their disease from. This is what the health protection regulations are there for. Let's narrow this down now really into the infection prevention and control as we know it, and most of us apply this in our healthcare settings. So you've got the laws in England, Scotland, Wales and Northern Ireland that set the provision to have standards that NHS bodies have to meet. So England was in 2008, Scotland's was in 2011, Wales piggybacks off the 2008, but they also had the Care Standards Act in 2000. And sorry, that bottom one should say Northern Ireland, not Wales. And their order was in 2003. So they established the legislation and the regulations that we have to comply with. So in England, we have the Code of Practice. And the reasons for having this Code of Practice are to make it clear to any healthcare provider what they need to do to comply, to make sure that they are protecting the people they look after and the people that work for them against infection. It gives the guidance for the regulator in England, the Care Quality Commission, to make judgments about the compliance with IPC. So they have standard against which they can judge it. It also provides the information for the people who use the services about what they can expect. And for our commissioners, it helps them to be able to understand what they should expect to the providers from where they're commissioning services from. I won't go through these for the sake of brevity, but these are all in the slide pack if you want to look at them in a bit more detail. But that's the Scotland ones, the Welsh and the Northern Ireland. But what I do have here for you is a standards comparison from the 4 countries. And you can see from this that whilst some of them are sort of slightly different in their sections, they all cover the same things. They cover the systems that we have in place to manage and monitor and the governance behind that. They cover the environment. They cover antimicrobial stewardship. That is in the Northern Ireland one under systems and governances. They cover the bit around risk assessment. They cover the practices that we need to be doing, whether that's under the policies or the isolation facilities. Some of them have very specific things in there. For example, I think the Scotland one is really good with what it says in there about its provision of equipment. And the Northern Ireland one is very, very much focused on practice in their last few ones there. And where you look at England and you think that education and training is missing, that comes into the policies and into the staff wellbeing. So all extremely similar, but they work in slightly different ways. All of them require a healthcare provider to be registered. Some of them monitor through inspection, some through self-assessment. They will look at public reporting and they will have ways of information gathering and intelligence. And what they gather from this will help them decide whether they need to go in and do a reactive inspection. Sometimes they go in and do themed inspections. For example, the Care Quality Commission went in during COVID and did a themed inspection around nursing homes and their IPC. They've recently been doing themed around maternity and neonatal based on the concerns that they've seen coming through from there. So a couple of regulatory examples here. The one on the left was a care home, and this was picked up when they were doing their inspections during COVID. And in this case, a care home appeared to have made a conscious decision not to follow the rules on wearing masks and gloves and was now in the process of being closed down by the watchdog due to safety fears. So they have the ability, these regulators, to close these organisations down. That wasn't just infection control for that one, but I think the infection control was the icing on the cake that led to it. We're on food examples today. For those of you in the first session, we had burgers. Perhaps the infection control one was the top bit of the bun that made this place be closed down. And the one on the right is a mobile medical private ambulance service. And when the regulator went in, they found that there was equipment with blood on it. It was dirty. The schedules for reviewing, cleaning just weren't in place. So they suspended their license to practice for a period of time. They did get their license to practice back again, but they had to address the CQC concerns. So I think it's important that we focus a little bit on what happens if you have an inspection by a regulator and it's not good. So I hope you all had a chance to read the CQC feedback that I asked you to read at the last session, but I'm going to summarise. Now, that feedback is real. I've not made it up. It's a real report, and it was a private cosmetic type surgery provider in the London and home counties area. And when the CQC went in, they found poor cleanliness in clinical areas, furnishings that weren't suitable nor well maintained, the cleaning schedules not documented nor audited, no system in place to provide assurance of cleanliness, inadequate sterile field management. I think they were opening packs the night before, if my memory serves me correctly. If not, I know somebody else was. Staff didn't know about their sterile or aseptic technique. Back to cleaning again, mop heads not stored or managed properly, gloves not changed, hands not washed, no dedicated hand wash sinks. Think sink. I remembered that from yesterday. Lack of systems to monitor for surgical site infection, which is clearly important in any healthcare setting, but possibly even more important in the private setting where you rely on people coming to you rather than being pushed to you. No risk assessment against the environmental standards, and exposed concrete in areas undertaking surgical procedures. So not complying with the guidance around what type of surgical procedures are appropriate to be carried out in certain areas. So I'm going to get you to go into your groups again now. So if we can, Crystal, if you can prepare us to go into 3 groups again. And if we can have 7 minutes in the groups, I think that would be absolutely fantastic. Thank you. And I want you to think about these areas. How are you going to make your staff aware of what they found? What are going to be your priority areas? And what documents would you prepare ready for when the CQC re-inspect? So I think I think we're enough. I think we've got 10 minutes. So let's get you to chat about that in your groups. You can even chat about any experience you've had of inspection and regulation by the CQC and responding to them. And then if you could come back being prepared to give us some feedback on what you've discussed together as a group. So 10 minutes, Crystal, would be lovely. Thank you. That was, yeah, so that was really helpful feedback. Thank you. I think sort of the summary from the feedback is about using your huddles and everything, and the example about using the risk register and the risk assessment was absolutely great. That's brilliant. Thank you very much. So let's think about assurance and reassurance. So we need assurance when it comes to IPC that we are doing the right thing. There's a difference between assurance and reassurance. And assurance is stronger, but the 4 questions that we should really be asking ourselves is, do we really know what we think we know? Where do we get our assurance from? It's 5, sorry, not 4. How reliable is this assurance? What is this assurance telling me? And is the assurance proportionate to the level of risk the organisation is to take? So back to that example that I was giving you about C. diff, is we kept the audits as simple as we could for them. And there is like a continuum along here to balance assurance and reassurance. So the phrases at the top, I think, are really, really good examples of telling you when you've got good assurance and when you've got reassurance. So reassurance would be, it's okay because management or my infection control team tell me it is, or the staff on the ward tell me it is. It's okay in the middle because management have responded to questions from the board and this has given me confidence. So it's okay because I've asked the staff on Trinity Ward what they do and they've told me, and that's given me confidence. And assurance is, it's okay because I've reviewed various reliable sources of information. So it's okay because I've looked at our audit results, I've looked at our infection results, I've been down to the area to check. So I have that assurance now that Trinity Ward are doing what they should be doing. And there's some of the things underneath there to be aware of in each of these areas. So for reassurance, if you've got strong management personalities, they may dominate, but track record of success, professional expertise are really, really good reassurances. And if you haven't got any contradictory evidence, that's a good reassurance as well. At the other end, if you've got independence of information source, so for example, your audits have been done by an outside body. If you think of the decontamination, you have the Joint Accreditation Group, the JAG, that come in to do the accreditation for the endoscopy services. That would be an independent information source, which is strong assurance because of their independence there. The evidence of historic progress and outcomes is really, really good. And if you can triangulate it with the other information that I mentioned there, like your infection rates, what your audits are telling you, what observational visits are telling you, then you're now getting really, really strong assurance there. And the further you can be towards assurance, the better. Now, just wanted to touch on the responsibility within NHS organisations for IPC, so you can think about where all this assurance and reassurance sits. Very obvious who's got the overall responsibility. The Chief Executive has the ultimate responsibility. And even if, say, your Director of Nursing or your Medical Director are the DIPSI, then the Chief Executive still is the one who ultimately takes the fall on this. If you're in a smaller organisation, it would be the Chief Executive again, or the lead GP would be the responsible person there. The Chief Operating Officer has a responsibility to give the leadership support and direction. The DIPSI or the lead IPC person has to make sure that guidance is implemented and you've got a competent workforce. Managers operationalise the application of the guidance. The staff apply IP&C principles, and they have a responsibility for maintaining their competence and their personal health. And the IPC team, perhaps I should have put you guys at the top, their responsibility sits around the expert advice, the engaging with staff, having sustainable and reliable improvements, and epidemiological surveillance systems. So that should help you to think about wherever you sit within your organisation, what you are going to have to provide assurance for in your role. So in the English sector, we have the code of practice and we have assurance against the code. And what I'm going to do now is I'm going to come out of this presentation and I am going to show you. I'm going to stop sharing this screen and I'm going to go back in and reshare again. I am going to show you some examples of some assurance reports, and I am going to show you the NHS England Board Assurance report that we have for IP&C. Right. So this is, now we shouldn't have the same problem now because I haven't got presenters, so you should be able to see Excel. Okay, on here. You have this link to the Board Assurance Framework from NHS England, and it covers all the areas of the hygiene code. So 1, the systems are in place. 2, your governance systems. 2, your clean environment. 3, antimicrobials. Information on infections. Identification of people who are at risk and the isolation, and systems in place for contractors and volunteers, isolation facilities, laboratory facilities, and the policies within the organisation, the occupational health needs and obligations of staff. So that also can go into an overall of where you are in each of these areas. So if you go back to the first one I showed you, we're currently in the organisation and board systems. So it gives you a chance to pop in here what your evidence is. So there's a governance structure, which as a minimum should include an IPC committee or equivalent, including the DIPSI IPC lead. So you can just enter in there and say who the DIPSI is. Chris Scott Perry, I'm not going to type it all in. IPC, oh, said it's a long time since I've used this. No. It's okay. I've forgotten how to do the lines in here, but I could also type in there IPC committee minutes quarterly. Okay, if you haven't got these in place, then you can put them in, and the mitigating actions, exactly what Sinead was talking about. You can put any comments in there, and then you can rate yourself as where you think you are. Are you non-compliant, partially compliant, or compliant? So if I click on the compliant, then that changes that in the summary plots and the overall. So if you haven't already started using this, I would really recommend this as a way for you to be able to monitor your governance and provide assurance. You can use this at local level, you can use this at senior level. Okay, I'm now going to show you some infection prevention and control reports from some various different settings. I'm not saying these are the perfect examples of how you should do this. What I'm saying is these are examples of different areas, okay? So this one is Gloucestershire Health and Care Foundation Trust. So what they cover within their report, you can see their key achievements and challenges. And I think in an annual report, it's really important to cover that off. Say what you said you were going to do, and say if you did it. Their assurance against the code, the team structure, the governance. Then they go on to have the facilities and the estates elements in there, the cleanliness, all the way through there, the antimicrobial stewardship, and their audit results are in there, patient information, healthcare associated infection surveillance, their isolation facilities, lab support, policies, staff health and wellbeing, and their aims and objectives for 2023. So I'm not going to go through all the pages here because there's a lot of pages. These are on your links in the presentation, so you will be able to go to this and have a look and see if there's anything you would like to take from it. The next one I'm going to show you is South East Coast Ambulance Service, and you'll see there's some very similar things in there. It's setting out the responsibilities, the infection control team, the structure. Then they go on to the cleanliness. They include in there their flu vaccination programme, their work programme, incidents, audits, reviews, etc., and quality assurance visits. This is a primary care group, so it's only 4 pages long, but this is the annual statement for primary care for GPs. You only have to do the annual statement, not a formal report, but it's quite clear what you should have in there. Any events that have happened, what audits you've done, risk assessments, details on your training, and review and update of policies. So you're stating in this what they are going to do. So it sets out who is the lead here in this one, what incidents they've had, etc. So that's a smaller version, but still has the same things. Because we have a lot of people now that come from the hospice setting, I have included this one from Marie Curie, and it's quite a detailed report because they're a large organisation and very similar things to what you've seen in the acute trust and the ambulance one. So they include the COVID board assurance framework, which is the precursor to the one that I showed you. They've got the incidents in there, they've got their surveillance. Interestingly, they talk about sepsis, which I think is really, really good. They've got their audit programme, they've got antimicrobial stewardship, training, the water safety estates and facilities, etc. And then finally, this is a integrated care board one. It's BNSSG, Bristol, North Somerset, South Gloucester integrated care board, and they obviously give the overview to this. So they start with showing an overview of what the increase has been, but they've got the key target organisms in there. Then they look at their comparison against the other areas in the Southwest. They look at the learning from the events, themes and trends. And now we're on to significant events, themes and trends and learning from safeguarding. So you can see that it's expected that depending on the level of what you are doing, the level of reporting that you would put in will be slightly different. So more detailed in your acute trust. For the ICBs, obviously, it's a what's the word I'm looking for? It's an accumulation is the best word that I can think of in my brain at the moment of the information from around other areas. But ambulance providers, GPs, you're all required to do this. Hopefully you'll get a chance to go and have a look at those governance reports. Just Google online and you will see a number of other ones around. And there's always something that you can learn from how other people present information. I do have a slide which sort of sums this all up, but I'm not going to bother to go into the sharing at this stage. I am just going to stop talking, I hope, and ask if you have any questions on that session about regulation and assurance, or if there's anything that any of you would like to share. No? Pop your cameras back on, those of you that have got them, because this is the last time we're going to see you all together. Any questions? That anybody want to share anything? Because you're all from so many different areas. Anybody want to share anything about how you provide your assurance? It doesn't have to be massive, big infection control committees. If you're in a GP practice, your IPC might be going through your quality committee, but you have to be showing somewhere within your organisation that you're doing that. Sunday.
I think, I believe assurance are better provided by creating an atmosphere of good psychological safety. When people have psychological safety, they are free to speak up, they are free to do their job in the right way, because they know even when they make minor mistakes, people who will investigate it or the management will look at it in a system thinking way, and then there will not be something like punitive approach to dealing with issues.
You're absolutely right, Sunday. You know, that links right back to where we started on with raising concerns and the difficult conversation, that psychological safety and that culture of this is important right the way through, you know, whatever organisation you're in. That's what would encourage people to do the right thing and to speak up when things aren't right and to tell you, because what you don't want is to go in and be auditing and find it's gone wrong. You want somebody to come and tell you before it gets to that stage, because that's definitely the best way to work. Thank you for that contribution. Okay, Crystal, can we get the evaluation form up ready? As I said at the beginning, really appreciate your feedback. A thanks from me for being a great group. You've participated really well in this. I've learned from you guys. It's been great that you've contributed in the sessions, because that makes such a massive difference to what we all learn from this course. For those of you that are doing your assignment, good luck. For those of you that asked for additional information, I will pop what I can find in the discussion group for you. Please continue to use the discussion group. It will be there for the 9 weeks that I said you have that access available on the RCN learning management system. Chenga, thank you for your thank you. I have to thank Crystal and Bettina because they are so integral to our delivery of this. And there is behind the scenes, there's also Chelsea, Lena and Pablo that help us with this. But, you know, Bettina and Crystal, thank you for your support for this. And Crystal, thank you for sorting me out. Now I've got my 2 screens that I didn't quite know what I was doing with, but I think we got there in the end. Perseverance, and we get there. While you're filling in your evaluation forms, are there any more comments or questions, infection control wise, that anybody wants to ask while you have us here? No? Okay. Oh, thank you, Crystal, for popping that in the chat there. Have people got the evaluation form up? Is it? Yeah, we just checked. Sometimes we have a problem with the loading if you need to go back in and restart your LMS, but it looks like everybody's in there. Thank you, Amy. Please feel free to leave when you finish doing your evaluation forms. Just say bye to us all, because it's been lovely having you all in this course. It seems such a short time, we get to know you and then you disappear. So yeah. And again, yeah, Deb, thank you for sharing your learning as well. It's been really helpful. We all learn from each other, like I said, and that's been absolutely great. So please give us your feedback.
Sorry, where is the feedback form?
Crystal popped it in the messages. There's a link in the chat. Have you managed to get to there, Sinead? It's further up, I think.
I've just sent it again.
All right, just popped it in the chat again. So it should be there. Now, we do know that some of you sometimes have, yeah, that's fine. You carry on. That's fine. I know you'll fill it in for me, won't you? Sometimes we have firewall problems, which we understand. And hopefully everybody will be all right this time. And I'm just going to carry on rabbiting and chatting. I hope you saw that I popped in the discussion page that the latest prevalence survey in the UK has now been published. There it is. And while you're doing that, we'll just summarise, goodness, list of tables and lots. So the overall prevalence of healthcare associated infection, which included NHS community and mental trusts, was 7.6%. So acute trust for 8%, so it's up from 6.6%. Specialist trust 16.6% up. So the message is that we can't take our foot off the gas for our infection prevention and control, because it's not going in the right direction at the moment. It's staying the same. We will get to an irreducible minimum at some point, but what we don't want to see is it going up. So the fact that you guys have come and done this course for us is brilliant, because we love to share the knowledge and we love you to go and implement it in practice. So thank you. I'm going to shut up now. Just checking, Crystal and Bettina, are there any other notices that we need to give?
Not from me.
Not from you. Bettina, any other notices from yourself?
No, nothing from me. I was just going to actually, just reminded me actually one thing around the certificate. So just to remind the students that anybody studying without credits will receive their certificate next week. Anybody studying with credits will receive their certification once the assignment has been marked and then verified by the Coventry University Board.
Thank you. Thank you, Bettina, for clarifying that. That is something we get asked, so thank you for remembering that one. I'd forgotten it as well.
That's me done. Thank you very, very
Thank
much,
you.
everyone. Lovely to meet you all.
Nice to meet you. Bye.
Bye-bye. Bye.
Thank you. Bye.
Bye.
Thank you. Bye.
Thank you so much. Thank you.
Lovely
Bye.
to meet you. Bye. Thanks.
Bye.
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 Bye. Bye.
Bye.
No, I can't leave.
Thank you.
Thanks. Bye.
Thank you. Bye.
Sarah managed to leave in the end then. Oh, we can probably stop recording, Crystal. You're going to have to cut all this out now.
Thank you.